Hello, this is Dr. Ahilasamy from Chennai, India. I am going to show a case of bilateral SinoNasal Polyposis or CRS with NP under local anesthesia. He is a 41-year-old male. He visited me 2 years back. It's a CTA coronal scan you can watch. I advised surgery 2 years back. He came, didn't return, and came back after 2 years. You can see the left nasal cavity is full of polyposis up to vestibule and into the choana and nasopharynx, and all the sinuses are involved, and there is some opacity on the right ethmoids and nasal cavity also. You can see the polyp in the choana nasopharynx also. So I treated him with a week of prednisolone to shrink the polyps to do a better surgery. This soft tissue window scan which shows that there is no fungal element, there is no double density or heterodensity. So it is a clear case of CRS with NP or sinonasal polyposis. This coronal CT pictures. Again, I am showing. I want to take under general anesthesia, but the patient kept on stitching for local anesthesia. He traveled a long way to operate under me to for a local anesthesia because he is afraid of general anesthesia and the complications of general anesthesia. Under local anesthesia, we operate in the morning and we discharge the patient in the evening. We do not pack the nasal cavity for any of our nose or sinus surgeries. See, this is a patient, this is a diagnostic endoscopy on the table, full of polyps. In fact, polyps were up to vestibule. With 1 week of prednisolone, it has shrinked and gone back beyond the inferior terminal on the left side, but anterior to the middle terminal. Gross subtle deviation to the right side, inferior terminal hypertrophy, hardly you can see anything more. Do repeated packing with Olagas soaked in 4% lignocaine and adrenaline in the ratio of 1:1. That is 10 ml of 4% lignocaine and 10 ml of adrenaline. After decongestion, you can have a better view. I am taking under moderate sedation, that is with usually I use dexmedetomidine with fentanyl. In this case, I am using remifentanil with propofol in infusion pump. Repeatedly pack and decongest the both the nasal cavities. Now, after decongestion, you can see, you can do the endoscopy. You can see polyps in the middle meatus on the right side also. Again, repeatedly pack to get a good decongestion with a solution of 4% lignocaine and adrenaline in the ratio of 1:1. With a moderate sedation and good packing and good blocks, you can comfortably do, and the patient will be very comfortable, thankful to you under local anesthesia. Use now I am giving the anti-ethmoidal nerve block on the left side. I can't give any more blocks. That's a spinobalton block on the left side because of the whole nasal cavity is filled with polyposis. Now I am giving this spinobalton block on the right side because I have the space. It is done with a 23 gauge needle with a solution of ropivacaine, 0.5% ropivacaine with adrenaline. For 20 ml, I use around 15 drops of adrenaline. Now I am going for the greater Pelton block or the transoral spinal Pelton block for the left side. Palpating the foramen, then I am using the 23 gauge needle bent for around 2 centimeters, trying it's not going into the foramen. Only the spinal pallidum foramen, sorry, greater pallidum foramen is the only foramen that can allow the needle. You may miss the needle, but you can get it by palpation and repeated. Now I have gone into the greater pallidum foramen. I will be injecting around 1 to 2 ml of ropivacaine with adrenaline for a good anesthesia. Patients are very, very comfortable with the moderate sedation. Do not oversedate their patients. Always aspirate and inject. Do not inject into the nasopharynx or into the vessels. Now I am using the shaver to take out the polyp. In fact, this is a shaver I have bought from Vansari Marketing some in 2006. That is around 18 years back. Still, it's doing good job. And I use Medtronic, the Zomed deburrer blades. It's not that you have to go for a costly shaver system. This Vansari Marketing have a very good shaver system, and you if you use a Zomed blade, it works well like this Medtronic shaver system. But the maintenance of the shaver system is very important. I am taking multiple biopsies because many people thought that it's an inverted papilloma, but I have to prove that. But clinically, it doesn't look like inverted papilloma, but still we have to biopsy the patient. If you want to buy this debrider, which I am using for past 18 years, of course I am using Zoma debrider also. This one you can contact Bansar Marketing. Dr. Naresh is the owner of the Bansari Marketing. You can personally message me. I can give you his contact number. And the service of it is very, very, very cheap. Maintenance also very easy. Of course, you have to maintain the motor, that is a handpiece, by good washing, suction, and oiling the handpiece. The whole procedure is done with this Vansari Marketing shaver system with the zoom and deburrer blade. Of course, the suction is very, very important. Here I am using the central suction because I operate in only corporate hospitals. I am taking more polyps for biopsy because I should not miss a IP in this case, that is inverted papilloma. But clinically, it is a very clear-cut case of SinoNasal Polyposis or a CRS with NP. Still lot of polyps in the choana and nasopharynx, which I am trying to shave it out with the deburrer system. You can appreciate the field quality, hardly any bleeding. In spite of we don't give any hypotensive anesthesia under local anesthesia. Hardly any bleeding. It looks like almost like a cadaveric field. You can appreciate the field quality. More polyps for biopsy. For FESS, never operate with a shaver system. If you can't go for a high-end costly shaver system, you can go for a, as I am using this Vansari Marketing Dr. Naresh deburrer system. Now we have got the normal anatomy after removing the polyp. That's the first step. For added benefit, I am giving a sphenopalatine block after I can see the sphenopalatine area. Now we have got the normal anatomy after removing all the polyps with the saver system and some for biopsy. Now I am using Dr. Ahila's my innovation unsnare dissector. It's a very beautiful tool. You should have one in your rack or in your tray. You can very well beautifully dissect the uncinate. In one stroke, you can dissect the whole uncinate and go into the maxillary sinus. Again, appreciate hardly any bleeding under local anesthesia and the field quality. I am using a STOS camera and a STOS 0-degree telescope. Later, I will be switching to the STOS 70-degree telescope for maxillary and frontal work. There's a dissector beautifully dissecting the uncinate. And already we have entered the maxillary sinus. You can have a good look of the maxillary sinus too. Please watch these videos on a big screen. Do not watch on mobile. Please pair it with a big screen of your TV or a infotainment system in your house. Now I am using scissor to cut the superior and lower end of the uncinate rather than pulling it blindly, shearing the mucosa. The uncinate has come out in toto beautifully. That's a view of the bulla and the maxillary sinus. See, the BP is around 156. We don't give hypotensive anesthesia and the pulse was around 70. Of course, this was done under moderate sedation of dex. We usually use dexmedetomidine with fentanyl. In this case, I used remifentanil with propofol. So I am removing the bulla with the brachiocephalic forceps. Of course, you can use a shaver, but the bone bits get trapped and block the shaver bleed frequently. After removing the bulk of the uncinate, I am using the shaver. The same shaver. This shaver does the same work if you use the Zomat Medtronic blade and a good powerful suction like central suction or a good suction. Now that's a Parsons ridge. That's a superior turbinate. Posterior ethmoid has been entered. Do not peel the mucosa unnecessarily. Loose bony fragments like that hanging has to be removed. Again, appreciate the quality of the field. Now I will be removing the Parsons window and will go into the sphenoid sinus, which was hazy in the CT scan. I am using the true cut or the true biting forceps. Now I have entered the sphenoid sinus. I am widening and using saver to widen it out. If there is fungus or more polyps, I will use the kerosene sponge to take down the inferior, inframedial and lateral parts. In this case, there is not much pathology inside the sphenoid sinus, even though the CT scan showed some pathology, all regressed with the 1 week of prednisolone treatment. Do not destabilize the middle terminal. It should be rock solid, sticking to the septum. Otherwise, the postoperative result will be bad. Now I am going for the frontal, clearing the frontal recess with the 45 brachiocephalic forceps. Next, I will go for the 70-degree telescope and clear all the blockage in the frontal, which are all opaque in the CT scan coronal study. More polyps there, you have to clear all them. Now I am going for a 70-degree telescope. That's curved sucker in the frontal, but still lot of polyps blocking it. So I am taking a rat cystic blade of the Zomet. You can attach it to the Ansari marketing defibrillator system, and there's a big polyp from the frontal coming out. Unless you do a good these jobs, the patient will not be happy or the disease will recur. Of course, the patient needs a long-term medical treatment after that with nasal douches, steroid vaso sprays. A very good view of the frontal sinus, frontal butt, that's posterior of the frontal sinus and everything. It's now clear, absolutely clear. Of course, we can't give washes under local anesthesia, otherwise the patient will aspirate. Any blood trickling into the choana, please suck it or ask the patient to swallow. Otherwise, the patient will aspirate and keep coughing and disturb your surgery. This patient is very comfortable, and you can see they appreciate the field quality. Maxillary sinus in this case is also okay and beautiful. Now I am going to the right side. There were some polyps in the right middle meatus originating from the right frontal recess. Using the same shaver system, to take out the polyp. You can appreciate the field quality under local anesthesia in spite of the BP is around 150 and pulse around 70. Never operate these kind of cases without a shaver system. Now we have got a good normal anatomy. Again, now I am using Dr. Ahilas, my innovation and snare dissector. In one stroke, you will dissect the uncinate and you go into the maxillary sinus. That's the beauty of this instrument. You can see the maxillary sinus, you can see the uncinate very clearly dissected. Appreciate the quality of the field under local anesthesia again. Hardly any bleeding. I am using scissor to cut the upper and lower end of the uncinate. Of course, this is an edited video. I am edited from around 55 minutes to around maybe 22 minutes. But the whole quality will be like an unedited video. So the uncinate has been removed. Next, I will be removing the bulla. Of course, in this case, the disease was very less on the right side. There is some significant deviation of septum to the right side, but I can manage. So I will not be doing a septoplasty in this case. Of course, if you feel, you can do it. All the loose bony chips has to be removed. Now I am wearing the MMA. Some tags has to be removed. You would have seen I hardly use suction at any time in the surgery. Very rarely I use suction. That's the beauty of doing under local anesthesia, and the field quality, clarity, excellence, so that you will avoid lot of complications doing under local anesthesia and the anesthetic complication of general anesthesia too. Friends, dears, and everybody, please start learning to do under local anesthesia, and you can have a achieve a lot, and the patients will be all very happy. We do all these cases the daycare procedure. Previous night I operate, admit, and the next day morning I operate, and same day evening I discharge. We never pack any of these cases, and no pack, no painless pack removal, etc. etc. And we start nasal douche with salt water saline from the second post-operative day with a red rubber bulb or with a 20 cc syringe. Awesome to blow. From the second post-operative day also, we ask them to have a steam inhalation at night to reduce the congestion. We start on intranasal corticosteroid sprays after 1 week. See, the right frontal is also opened, hardly much disease there. Except right sphenoid, which doesn't have much disease, all the signs has been opened, and a full bilateral FESS has been done. And you see hardly any bleeding, no destabilization of the middle turbinate, rock solid middle turbinate, and patient is very happy and no pain during surgery. Loose bony chips, take it out. This is a post-operative picture at the end of the surgery, and any blood collection in this nasopharynx, please suck it out. Hardly any collection in the oral cavity, throat also. Thank you for watching, and you can see at the end of the surgery also the BP is around 156/81 and the pulse is around 71, saturation 97, no drop in saturation. Thank you for watching. You can contact me at any time in the below address. Thank you again. See you in another beautiful